welcome back to another episode of Recharging the Human Battery here on AM 950 Radio. Dr. Sinacropi is out today, so it's just me, Mandi Dickey, nurse practitioner, running the show today. So as I've done in some of the previous episodes when I'm here by myself, I'm doing the TBI takeover day today. So back to the ABCs of concussion. We've done letters A, B, and C. Today is letter D. So I bring you some more topics starting with the letter D that are related to concussion and TBI. And again, why am I doing this on a Recharging the Human Battery show? Our brain is one of our biggest batteries in our body. You can always find a neurologist and a cardiologist fighting over which one's more important, the brain or the heart. But even if your heart is pumping, you still need a brain to tell your body what to do. And we all have brains, last I checked. And here in Minnesota, in the Midwest in general, we're in the cold, icy weather. Now's a really good time when we see people coming in because they have fallen on the ice and they hit their heads. And whether or not you hit your head, honestly, we've talked about this before, whether or not you hit your head, you can still end up with a concussion. So that's one of those big things that people always think about is, well, I didn't hit my head, but I don't know why I'm not feeling great afterwards. So it's not just your body that takes the impact. Your head also takes the impact when you fall, when you hit your body on something. So it does not have to be that head impact that causes a concussion. So again, as I'm talking through these letters, if you have symptoms that have been there for a while and you don't know what's causing them, think about what happened right before those symptoms started. Did you have an injury that may have potentially caused a concussion, or also known as a TBI, traumatic brain injury? So think about that as we go through these topics. And again, the topics that I have for you today, I'll start with the letter D. I will start with the first one a little bit here before we go into the break, and then just kind of give you a little teaser on that so you know what you're listening for when you come back from that break. The first topic that I'm going to talk about today is diagnosis and diagnostic tests, meaning when you think you have a concussion or you've been in an injury, how do you get a diagnosis? How do we even begin that process? And getting a diagnosis of concussion can be really tricky because there are a lot of symptoms that can be involved. Not everyone has those symptoms. Again, if you didn't lose consciousness, it's not the first thought that people have that maybe you have a concussion. So getting that diagnosis can be really tricky. There are not a lot of diagnostic tests that will confirm it 100%. There are some that can help us with the diagnosis, but there's not a lot that confirm absolutely you've had a concussion. So diagnosis of concussion and TBI is largely a clinical diagnosis, meaning that clinical examination helps to do the identification, getting that history, doing that physical exam. That's really what we use to get that diagnosis, since we don't have a lot of really good diagnostic testing for it. So that diagnosis can be very subjective depending on which symptoms you present with, how severe those symptoms may seem, and I will add to the knowledge level of the provider doing the assessment. Not all providers are created equal in this game. It's not that you can go to any particular provider and you will get the same diagnosis as you would to go to anybody else. It depends on the level of experience, depends on the level of knowledge. Even if you go to a neurology provider, most neurology providers have a niche. They have their thing that they specialize in. So all of them are really good generalists. They know a little about a lot of things, but they don't know a lot about everything. And you still might not find that provider that knows all the things that they need to know about concussion. So it's still possible to go to even a neurology provider and not get that good diagnosis. So some of the diagnostic testing that we do, there are some that we routinely do when you come in for an acute head injury or a chronic injury, if we're looking for more symptoms like that. And then there are some of the tests that I'm going to talk about today that are more hard to find. They're not widely used. They're not may or may not be covered by insurance, but I'm going to go through those when we come back from the break. So things that you think about all the time, head CT, MRI, we'll talk about those, plus the others when we come back on the other side here on AM 950 Radio. Welcome back from the break here on AM 950 Radio with Recharging the Human Battery. Again, Mandi Dickey, nurse practitioner, here today covering the episode, doing another one of those TBI takeover episodes. So talking about concussion today, back to our ABCs of concussion, letter D today. And I kind of started a little bit before the break talking about diagnosis and diagnostic testing and how do we even get that diagnosis of concussion. So to start off with, one of the first things you might have done if you just had an injury, you were in a car accident, you had a fall, you had some sort of injury that you know that you had it and you're going in to get an evaluation. Typically, one of the first things they do for diagnostic testing is a head CT. We don't expect there to be anything wrong on that head CT, to be honest. When you're getting that done, it rules out the possibility of bleeding in your brain. So that's the one thing that we don't want to see. So if you fall, you hit your head. You get in a car accident, you hit your head. You hurt yourself in a sporting injury, hit your head. We're going to get that imaging to see, did you have a bleed on your brain? Without that, that's really all that we can say is that you didn't have a bleed. We can't say that you did or did not have a concussion because we can't see those minute details on a CT scan. And sometimes we can't even see the bleed on there depending on where it is and how large it might be. Sometimes it doesn't show up right away. So that CT being negative at first does not mean you don't have a concussion. It just means that you don't have an acute bleed right now. The other test that might get done is an MRI. We typically don't do that on the first exam unless it's been a while that you've had your symptoms. Maybe you waited a week or two or a month or two, and now you're coming in for evaluation, or you're getting evaluation because you have these symptoms and you don't have an explanation for them. A CT is only helpful on the spot at the moment when you have that acute injury. MRI is going to be much more telling after some time has passed. So that's when you're going to get that MRI of your brain. But again, it's looking for a bleed. We can't necessarily see concussion changes on a regular MRI. So again, if it's negative for bleed, does not mean it's negative for concussion, just means it's negative for bleed. There is another type of MRI that sometimes can be done. It's called a functional MRI. You'll see that abbreviated with a little F before the MRI. That functional MRI can actually highlight changes in areas that are not functioning in your brain. So they highlight those in different colors, different color patterns to show areas of the brain that are not functioning as they should. Things that do not show up on your typical MRI. However, functional MRI is still very much considered a research tool only. So unless you're in a research study, it typically doesn't get covered. Insurance doesn't cover it. A lot of providers don't even order it. A lot of providers don't know how to read it. It does take a specialized practitioner to interpret it because it is very different from a regular MRI. So there is that drawback. It's that diagnostic test is there, and maybe at some point it will be more widely used. But again, right now, just used in research. Neuropsychological testing can be helpful. It can actually identify cognitive changes due to the concussion. It can't necessarily say, yes, you had a concussion, but it can identify the cognitive changes that we would typically see with a concussion. But it can take months to get into a neuropsychological provider to get this test done. It's usually a 2 to 3 month wait at any neurological clinic. And there is a caveat with that. Higher functioning individuals may not appear as impaired. So I have beyond a master's degree for my education. I have lots of certifications. I've had several years of experience in neurology, working as a provider, working as a nurse even before that. Mine still had me within normal ranges on several different areas, but my neuropsychologist said, given my intelligence and lack of education, she would have expected much higher. So again, individuals with high education levels might not show up quite as impaired on there because they still fall in those normal, I quote, normal ranges, but it's not normal for that person. This is when I say it would have been really great to have that test done as a baseline, but not everybody wants to go through just a 4-hour cognitive test just for the heck of it to have a baseline test done. So there is that caveat. There is another test that we actually do at Hypercharge called a qualitative EEG, so QEEG. And there are several locations around the Twin Cities that will do this test, and even into greater Minnesota, there are different locations as well outside of Hypercharge. So again, not saying that you have to come to us, but we would be an option for this qualitative EEG. This is not an EEG that you normally think of if somebody's getting evaluated for seizures. We're not looking for seizures. It's looking for brainwave patterns. And those brainwave patterns have specific disruptions that you can see based on a concussion. So again, that would accompany that clinical diagnosis to say, yes, you've had a concussion if we see those particular changes on the brain wave patterns. So another thing, that one is covered by insurance. You can submit it to your insurance company to get reimbursed, that is. So there is that one. There are other testing, such as computer-based exams, like the impact testing. So if any of you listening have children that play in sports, they likely have done the impact testing with their sports teams, whether it be high school, college. Also, professional teams use this. Military is using this now too. So you can see it used in several different settings. What the impact testing does is measure things like memory, attention span, visual and verbal problem solving. And they do baseline testing. So if somebody is getting into that high school or college athletics, they do impact testing at the beginning of your season, so that if you have an injury, they can retest you and see where are you compared to your baseline. That gives the team, the coach, the athletic trainer information on whether or not you can return to play. It's not a diagnostic tool by itself, but again, can be used in conjunction with these other evaluations to say, yes, you had a concussion, yes, you are impaired, and then yes or no, can you go back to that activity? Another test that we can do, another test that's available at least, is the automated eye tracking test for acute injuries. It's used by something called an eye box by Oculogica. Eye box was actually developed by a neurosurgeon working here in Minnesota, which is really cool. The test is based on the cranial nerve control of your eye movements. So when these cranial nerves are impacted by a concussion, the eye box can be used to give a score that measures absence or presence of concussion. If you want to see more on this, Dr. Samadani actually did a presentation as a TED-Med talk. So if you Google iBox by Oculogical, iBox is just EYEBOX. You can find the website that gives more information on there. There's the link right to the TED-Med talk. If you do want to take a look at the presentation by Dr. Samadani, it's really cool. The unfortunate part of this is it is still considered investigational. So it is not widely covered by insurance, but some insurers will consider it on a case-by-case basis. So there is that. And thankfully, though, a quick online search that I did found that it typically costs an individual only around $50 to $60 to get the test done. So it's not going to be a huge burden on your wallet to get this done, even though it's not covered by insurance. Most of the time, that's like a copay now. So another up-and-coming test that is possible, depending on where you live, not here in Minnesota yet, but there is a blood test that was developed by Abbott to identify with, it's been approved for use with adults suspected to have a concussion. It measures two different biomarkers, and I can't really pronounce them. They're abbreviated UCHL1 and GFAP. I'm not going to try to pronounce the words today, but if you Google, if you want to look at it, the Abbott blood testing, it looks at UCHL1 and GFAP, those two biomarkers. It was actually developed in collaboration with the Department of Defense, so that hopefully we'll kind of get this moving along a little bit faster too. It's an iStat finger prick test. So the results are available in about 15 minutes. What that means, iStat just means that we can do it kind of at the bedside in the emergency room. So when a patient comes in, we do a finger prick test. This one particular only tests plasma, so it still does need to get sent to the lab. They're working on a whole blood test for it so that it could potentially be just done at the bedside and the clinician can get the result at the bedside without having to send it back and forth to the lab. However, that said, it looks for the potential presence of bleeding on the brain. So a negative test rules out the need for a head CT because you wouldn't need to have it done. But a positive test can complement that CT in evaluation of a concussion. So a positive test, again, would say that, yes, you probably have a concussion. You still need to get a CT to make sure there's not bleeding on the brain. But yes, you have those biomarkers. It would definitely help to confirm that diagnosis. But again, unfortunately, it is still considered investigational. So it's not generally covered by insurance and it's not available in all areas yet. It is FDA cleared, and when I was looking this up online, I did find places mostly in Florida that are starting to use it. So it's not quite here in Minnesota yet, but hopefully at some point in the future. And Abbott has not released their pricing, so I can't tell you how much it costs out of pocket for it either, unfortunately. But it's another test that's coming, and it's really exciting to see all these tests that are up and coming, because it means there's still more research going on. This concussion is so huge. We still don't know the true numbers of it because people don't often report it. I've talked to so many people lately that they're like, "Oh yeah, I had this or that. I hit my head. I had a little bump on my head. I had a seen stars episode." But people don't always get seen for that. So our true numbers of how often this happens really are not available, and it's still just a big impact to our society. So there's our first topic. Second topic I want to talk about is dizziness. And we did talk about this a little bit with our balance discussion back in letter B, but somebody can feel off balance without truly feeling dizzy. So I did feel like dizziness needed a little bit more time on itself too. Why do we get dizzy after a concussion? There's some sort of disruption either in the vestibular system in the inner ear, or the neural pathways between the brain and the ear that process that vestibular information, or it can be from sensory conflicts when somebody has vision troubles, inner ear injury from the injury itself, or bodily injury that can cause you to be not symmetrical on both sides of your body. That can cause problems also. Other things that can play a role in dizziness are hydration, headaches, neck injuries, side effects from any medications you might be on, sudden blood pressure changes, such as with the autonomic nervous system dysfunction that we talked about back in letter A. And that autonomic dysfunction can also cause dizziness with position changes. So there are all of these different things that can play a role in that dizziness as well. If you have visual difficulties as part of your concussion, that's also going to add to that feeling of dizziness just by having your visual system not getting information correctly. What do you need to do for this dizziness? There is physical therapy specifically for the vestibular therapy. So that will work on that balance just specifically for that. And then I also recently learned about neurological chiropractors. So this is a group of people that I did not know even existed before. I've known about chiropractors forever, but this group that is more specialized in neurological practice, they practice more like functional providers. So they look at, again, the whole big picture. They do some additional testing that can help with dizziness, vision, all of those different things as well, including disruption of the optic kinetics in your eye that can cause some dizziness. I didn't even know that was a thing, to be honest. So learning more about that, I'm really excited to potentially bring more of that at some point to you guys also. And then vision therapy will work on the visual portion of the dizziness part. When we're talking about things like hydration, you do need to make sure that you're drinking plenty of water so that dehydration is not playing a cause, because it will worsen your symptoms. You need to eat a nice balanced diet, get enough protein. That will also help to kind of push off some of those symptoms of dizziness. Rest when you need it, and reduce stress as much as possible. Stress does not go away when you have a concussion or TBI, but you need to be able to manage it. Next topic then is depression. And this one, again, we've talked about mental health issues a lot in this ABCs of concussion already. But having depression prior to a concussion increases your risk of having depression following. So if you've had a fall, you've had a hit to the head, and now your depression seems to be worse, there is a actual reason for that based on your brain injury. It can be caused by changes in your quality of life because of symptoms that you have from the concussion, or actual functional changes from the injury itself. The brain injury can cause changes to the chemicals in the brain, those neurotransmitters that tell your brain and your body what to do, and that can lead to depression. People with persistent post-concussive symptoms are at a higher risk. I had an entire episode specifically to persistent post-concussive symptoms on my podcast, Brain Wellness, that we talked about all of these things and what happens, how it gets to that term of persistent post-concussive symptoms also. But having that, meaning you have those symptoms that just kind of linger, that puts you at a higher risk for having depression also. And looking at the numbers, again, numbers are kind of tricky with this one because not everybody reports their concussion, but about half of all of the people that have a concussion that are reported will experience depression in the first year because of some of those changes, whether it be chemical, physical, or just emotional changes. More than half of those people will also have anxiety. Again, we talked about that way back in the A letter. Treatment for depression after a concussion is just like those that for the individuals without a concussion. They would recommend medications and or counseling because both of them together tend to work better than one alone. Other treatments that can work: exercise. Exercise is one of the most underutilized antidepressants out there. It really can help to balance some of those neurotransmitters and get your brain functioning a bit better. Again, difficult though with somebody that has a concussion and trying to recover from that. Acupuncture, biofeedback, red light therapy, transcranial therapy, things that we do at Hypercharge also will work for that. The next topic is double vision. Again, talked about this a little bit with convergence insufficiency back in letter C. There can be cranial nerve injuries leading to the weakness in the muscle movements or incoordination of the muscle movements of the eye so that they're not tracking together. Double vision can also lead to balance problems and dizziness that we just talked about. And it might, again, not be distinctly two objects. So you might not be seeing really clearly double, but those two objects might be so close together that it just appears blurry. So sometimes people will just talk about blurry vision. Same thing in this regards. It can lead to a lot of eye strain and headache, sensitivity to light, difficulty focusing on objects, perception difficulties, so perceiving how far something is away from you, like depth perception, and then fatigue or headaches while driving or working on a computer or reading. So a lot of people might not realize that they had a concussion, but following that, they do get a lot of fatigue while they're driving. I actually had a friend of mine tell me this recently. Well, I get really tired when I'm driving. I get really tired when I'm on the computer. I'm like, okay, sounds like you might have some visual troubles related to that concussion. So needed to get that evaluated. And then double vision might be made worse if there are underlying visual difficulties. I had some underlying vision problems myself that lead to kind of worsening of the double vision from my concussion also. So definitely something to monitor and a reason why you need to get into a neuro-optometrist to get this evaluated. Double vision can go away on its own as the swelling and inflammation in the brain improves, but if it doesn't go away, you do need to see someone. So neuro-optometrist is really the one that you want to see, or a behavioral optometrist, because they can evaluate those neurological changes in the brain further. Or again, that neurological chiropractor would be able to do a lot of that testing also. Some of the treatments for it, again, OT vision therapy and the exercises that are related to that, prism glasses. Syntonics is a cool new therapy. I don't know if it's really new, but something I learned about recently, use of light therapy. So I did do this for a little while as well. I used different colored glasses and looked at a light source to help to treat those autonomic nervous system involvement with the vision. Distraction. This one's a really big, popular one among my TBI warrior friends and myself. It is really easy to get distracted. So in the letter C episode, we talked about concentration. So this is kind of the opposite of that. So if you can't keep that focus to concentrate, that would be distraction. Kind of like the ADHD conversation we had back in the A as well. But this is definitely something that happens to a lot of people with concussion, though there's not a lot of really good information online about it. So when I tried doing a Google search to have some research backing this one, it was really hard to find information about distraction. Concentration, sure, not the distraction part. So what do you do about it? But it's really easy when you have a concussion to get distracted in conversations. It's easy to get distracted when you're trying to complete a task. Not necessarily even just multitasking, just a task if there's something else going on around you. I had my first meeting with my neurological chiropractor this week, and there were conversations going on around us with that. And it made it really difficult to focus on that conversation, even over a year and a half in as I am. Prior to my injury, talking about personal experience, I could tune things out around me. When I was in nursing school, even I studied in coffee shops, had no concerns. I focused on my textbook. I could take notes. I could have conversations with people. I may or may not have music going on in my headphones while I was doing all of that, but I still had absolutely no problem focusing on my studying and remembering what I was reading. When I was working in a busy hospital, I could see my patients over and over with things going on all around us. They could be in a double room with other people in there. There could be care conferences going on at the desk. There could be all sorts of things going on, and I had no issue with any of that. After my injury, though, I have difficulty even placing an order in a coffee shop if it's really busy, trying to stand there and look at the board and figure out what I want to order, and especially depending on what time of day or day of the week it is. By the end of the week, I'm much more sensitive than I am on Mondays when I've had time to rest over the weekend. And it makes it really, really difficult to try to do any of those things. I did try a shadow day back on my old job, and being in the hospital again was way too overstimulating also. And multitasking, as I kind of mentioned earlier a little bit, requires the ability to split your focus between multiple activities at once. So since it's difficult to focus on one activity, multitasking really pretty much goes out the door. What can you do about being easily distracted? Again, when you try to search this up online, the only thing that they'll really tell you is that you need to avoid activities that require a lot of concentration for a few days after your accident, and then gradually increase your activities. And that's about it. But what if you're one of those lucky 30% or so to have persistent symptoms? What are you going to do about it after that? I say, listen to your body, take breaks when you need them. My therapist, as I was going through, my occupational therapist wanted me to do some desensitization. So I had a lot of trouble going into the grocery store because there were too many things to see, too many things to do, and my symptoms would get kind of overactive and I would get distracted on what I was doing. So I had to go in literally for like 10 minutes at a time with only one or two things that I needed. And she wanted me to purposely look around at the things around me so that I could take all those things in and get a little desensitized and gradually increase my time and my tolerance in that busy setting. If you have to do something that requires more attention, you need to stop doing other things. So I used to be able to, again, multitask. If I was working on something on my computer at home and my kids came up to talk to me, I could talk to them, I could do my thing on the computer, and I had no problems. But now I have gotten to the point where I have to ask my kids if they're coming up to me when I'm working on the computer to give me a moment. I literally put my hand up and I ask them to give me a moment so I can finish going through whatever it is I'm doing, whether it's writing out an email or working on a podcast or doing something. I need to get to a good stopping point. And then I look up and I give my child my undivided attention because I want to be able to remember what they're telling me. I want to remember that conversation. So again, if you're having problems with distraction, you need to remove the distractions. Focus on one thing at a time so that you can give your full attention. That's how you store something into your long-term memory. So memory goes right along with that. Recovery from this part takes purposeful activity so that you can increase your ability to focus. So you purposely have to focus on the things that you want to remember so that distraction does not prevent you from remembering it. The next topic I want to cover is disability, and this one is another big one. Post-concussion syndrome can be considered a disability depending on the length and the severity of the symptoms present. Most people have no issue getting their short-term disability from their work, but often that long-term disability gets denied, sometimes multiple times, and people have to sometimes get in with a disability lawyer in order to get that overturned and actually get their disability covered. When it comes time to apply for Social Security disability, that's also very difficult. Again, as a provider, I would fill out the paperwork for my patients and they would get denied. And we would do it again and they'd still get denied. And I know people on the other side of it are getting denied. I myself was recently denied. So trying to figure out what to do from that also. And I've had friends that were injured in car accidents around the same time as me, also fighting the same battles and getting denied their disability. So it makes it really difficult for people to try to maintain their sense of living when they don't have their income and they can't get that disability covered. So this is a huge financial burden on the community of people that are experiencing concussion and TBI. There is a lot of documentation required. So just to give you a taste of this, with the medical documentation, you need notes to describe what symptoms you currently have, whether you're still attending your therapy regularly, proof of any medications that you get, and proof that the prescriptions are actually being filled, because yes, they will go to the pharmacy and check. Documentation to prove that this is not a pre-existing condition. I had a history of migraines prior to my injury. So my long-term disability tried to deny it based on that previous diagnosis. So I had my provider write a letter to describe the frequency of my previous symptoms and the presence or absence of related symptoms. I was working multiple jobs because I was kind of that type A person. I had my full-time job and a part-time job. I had multiple jobs and I had excellent attendance records. So I was able to get both of my employers to write me letters that described the fact that I did not miss work prior to because of my previous diagnosis as well. And in fact, I worked above my scheduled appointment. So all of those letters helped to get it finally approved later on. But there's a huge amount of paperwork, not just for all of those notes and letters that need to be retrieved and sent in, but I also had multiple times when I had to fill out what seemed like 10 plus, I think they all were 10 plus page documents that I had to complete on multiple occasions, which is difficult to do when you have a brain injury. So being disabled from work itself is mentally exhausting, especially if you worked really hard to get into the job that you have. It's a career that you love. It can lead to depression because you're not able to get back to that job at that particular time. It can be a lot of anxiety over those financial changes, especially when you're fighting to try to get this disability in the first place. And you can have depression and anxiety because of physical changes, mental changes, and you can't medicate away the grief over being disabled from a career that you love. So that's very, very difficult to deal with. And unfortunately, post-concussive disability is still very much an invisible disability. So many people don't understand it. It's, you look like a normal person. You look just fine. You don't have physical symptoms from it. So how in the world can you be disabled? But I can tell you, it's been 21 months since my accident, and I haven't returned to being a nurse practitioner yet at this point because it's hard to be a provider and treat someone medically when you can't remember what their history and exam are once you step out of the room. So it's the things that you can't see. It's the memory problems. It's the cognitive difficulties. It's the depression, the anxiety, the visual difficulties. You can't see those things. So even when you see somebody getting out of a vehicle and they have a handicap sticker, if you can't see a physical disability, it doesn't mean there's not one there. And it's really hard for people to understand when they don't see that disability. So there's a lot of work into getting that disability notice. There's a lot of mental anguish over having it, and then everything else that comes along with it. Part of getting that diagnosis is identifying those symptoms. So the next topic I want to talk about is delayed symptoms. When we have a delay in symptoms, it does delay the care too, because it makes it more difficult to get that diagnosis. Most people think about concussion as the symptoms appear right away after the accident. You hit your head, your symptoms show up, maybe within a couple of hours, but people think about it in that general relationship. You have to have the injury followed by the symptoms immediately to get that diagnosis in many people's heads. But again, it's not the truth. It might take days or weeks for symptoms to appear. So they don't have to be present right away. You can have an accident injury and feel fine right away, but several days later, several weeks later, then you start noticing that your vision isn't quite right. You have the headaches, you have the perception issues, the sensory issues. Any of those can take days or weeks to show up. But I will also say it could be months or years before you can really acknowledge those symptoms. I'm not saying that it takes months or years for them to show up, but it's really months or years to acknowledge their presence when you really kind of step back and say something's not right. And some of those symptoms might not be appreciated or noticed right away because of the severity of other symptoms. So I call that kind of like peeling back the layers of an onion. Once you treat some things, you realize what else is involved and you shift treatment to that newly uncovered issue. For example, I had really, really bad headaches for months after my accident. And I had memory issues. I had cognitive issues at that point, but my provider kept thinking that it was related to my headaches. So it wasn't until the headaches really started to taper off that we realized how significant my cognitive issues were, because again, we were attributing them a lot to the headaches when they weren't really. It was a separate issue. We just weren't able to address it or identify it until we took away one of those other symptoms. So again, peeling back the layers of the onion. You find one thing, you treat it, you find something else, then you switch gears and you treat that next thing. Sometimes long periods can go by without identifying the cause of symptoms because the symptoms of concussion can be somewhat vague. you have headaches, you have fatigue, you have maybe some nausea, it might look like you have the flu. And if it's in flu season, so we're in flu season, but we're also in fall season. Either of those can happen. Two things can be true at once. You can have the flu and you can have a concussion. And it's really hard to kind of tease out what's going on with that. But sometimes, again, because those symptoms can be really vague, if somebody fell, didn't hit their head, they were in a car accident, didn't hit their head, they were playing sports, say in hockey, when you get checked against the wall, don't hit your head, but your body hits the wall. Maybe you have one of those injuries and you didn't hit your head. So again, people still kind of get stuck on that fact that they think you have to hit your head to get a concussion, but if you don't, so if you have one of those injuries that does not involve a head hit, a lot of times people won't put two and two together and they won't think that, oh yeah, I had this injury. Oh, I might have a concussion. So it leads to delayed diagnosis because they're not even realizing that that could be the problem. And if they're not attributing those symptoms to the injury itself, then they might get misdiagnosed with other things. They might get diagnosed with a fatigue issue. They might get diagnosed with sleep problems. There are so many different things that they could get diagnosed with accidentally instead of the concussion itself. So again, if this might be you, that you're listening and you are experiencing any of the symptoms that I've talked about in any of these ABC of concussion topics, think about what happened. So if you don't have an explanation why, think about how long you've had those issues. I think I talked about this back with ADHD, but if you suddenly have a new diagnosis of concentration issues or vision issues, have those symptoms been present your whole life or not? If the answer is no, then you need to think about when they started. And were there any injuries that happened around the time of those symptoms starting that may have led to a concussion? If that answer is yes, then I would recommend that you get in to see a provider because it really is never too late to get this identified and treated. And it used to be with any kind of head injury. I worked in the stroke area for years, and we erroneously told people that once you got to the 1 year mark, if you hadn't gotten better by that point, that was as good as you were going to get. And then I met somebody at a conference who was like 7 or 8 years past her injury, and she was still getting better. So I stopped telling people a time frame. And that's really hard on the patient to be told that. And on the patient side, myself, after this concussion, it's really hard for people to tell me that I'm not done getting better yet. But I can tell you, again, at 21 months, I'm still getting better. And every time I find a new therapy to try, that helps me even more. So it's never too late to get that diagnosis. It's never too late to get those symptoms treated. So again, if it's been a while, you may or may not know what's causing those symptoms, get in and get evaluated. That's my soapbox on that one. I will step off my soapbox and we'll go on to the next topic now. Driving. So I want to talk about this a little bit before we take our last break for today. Driving can be affected by mental or physical concerns after a concussion. What does that look like? If you are having physical problems, we talked about the vision difficulties. We've talked about headaches a bit, balance, fatigue. Any of those things can lead to difficulties with driving. The vision, especially if you're having double vision, takes a lot of focus to be able to see where you're going, what you're doing. And that puts a lot of strain on your brain. So it's usually time limiting, meaning you can only drive for 20 to 30 minutes at a time or less, but that will improve as you recover. I went from 30 minutes at a time, that was kind of my max for a very, very long time, to now I have gone an hour and a half with my driving. But I haven't tried anything beyond that because once I get there, I still have to do whatever activities it was that I was driving to get there for. And then I have to turn around and come back from that. So I haven't tried to push myself beyond that hour and a half time frame yet, which kind of stinks because I have some friends that I would like to go visit. But it does improve. It does get a little better with that. The mental parts of it, PTSD can be huge. And whenever we get to that P letter, I will go much more into detail into the PTSD part of it. But I'll leave you on that note just for a quick moment while we go to our break. And I'll come back and talk more about the driving. And then my last D topic here on AM 950 Radio, recharging the human battery. Welcome back from that little break again here on AM 950 Radio with Recharging the Human Battery. One last time for today. Again, Mandi Counters, nurse practitioner, here today with my TBI takeover. We've been talking about all of the topics that start with the letter D for the ABCs of concussion. Today, lots of different topics that we have covered today. They've all been really near and dear to my heart as I've been going through my TBI recovery. And this last one that I left you off on before the break was driving. So again, can be affected by mental or physical concerns. Again, those physical things being vision troubles, headache, balance, fatigue, any of that can lead to that difficulty with driving. The last one I was mentioning was that mental piece of it. So PTSD, post-traumatic stress disorder. A lot of people kind of poo-poo this and they don't think it's a really big issue. But if you've talked to anybody that's come back from any kind of military experience or they've been in any kind of big accident, they think of it really often because things flash up into their head. You have flashbacks to the episode. You have anxiety related to it. For a long time after my car accident, I would have visions of that same accident anytime I was going through any intersection, to be honest, but the intersection where the accident happened, absolutely. And I would have panic attacks going through those lights. I'm not a panic attack person, so this was a very, very difficult and different experience for me. And trying to identify why it was that I was so freaked out didn't make any sense. I was the passenger, but being a driver in the vehicle actually gave me more anxiety than it did being a passenger again. If I was driving down the road, I would see an emergency vehicle go by me. Didn't matter what kind of emergency vehicle, that would cause a panic attack. So that PTSD was very disabling when it came to trying to drive anywhere. And it was very, very limiting. So I did do a phenomenal treatment for that. So treating the issues with driving, you have to treat the underlying problem. If it's a vision issue, going to the vision therapy, working on the vision side of things. If it's PTSD, you need treatment specifically for that, such as EMDR. And that will be one that I'll talk about more way down in the E. I guess that's not that far away since we're on D. One episode away from that one. Probably a few weeks from now. But EMDR, eye movement desensitization and retraining. So retraining your brain so that issue is not as big of an issue for you so that you can go on with your life. It took about 2 to 3 months of treatment, and it was phenomenal. The day I had an emergency vehicle go by me in the car and I had no increased reaction to it whatsoever. So EMDR is the real deal. It's a really good treatment for PTSD. And it's really good, really important to get that treated, because if you have PTSD in addition to your concussion, it will actually slow your recovery. So you need to address these different things. The very last topic that I have for today to wrap up is, I suppose, probably save the worst for last on this one, diffuse axonal injury. And it's probably one of the most severe forms of concussion and TBI. It's a specific type of TBI from a blunt injury to the brain, typically caused by things like domestic abuse. This would be like the shaken baby syndromes that we used to talk about. Motor vehicle accident, rapid falls, direct hit to the head in sports. It is the leading cause of death and disability in children and young adults, and falls into that severe TBI category. There's often a GCS, a Glasgow Coma Scale. This is a scale that we do to evaluate somebody's mental status and mental state of 8 or less. And I remember in school, GCS of 8, you tend to intubate these people. So these people are on ventilators, on respirators, helping them breathe because their brain is damaged to the point where it can't remember to breathe. That GCS of 8 or less for over 6 hours. It's largely a clinical diagnosis. MRI might see some little punctate, little tiny bleeds in the brain, but it's a very, very high mortality, unfortunately. This is not something that we see very often. It's only 10% of the severe TBI cases, which is a low number of all the TBI cases overall. And I hate to end on a bad note, but I did feel the need to just kind of throw that in there. So again, lots and lots of topics for today. If you think you might be somebody who has a TBI, please get it addressed, because we all have brains. We all need to take care of them. And I will be here to give you more information next time here on Recharging the Human Battery on AM 950 Radio.